Good evening, everyone. I welcome you all to yet another ISA online PG class where we discuss interesting and important topics every Monday. I'm Dr. Himani, working as Associate Professor in RIMS Adilabad, and here with me I have Dr. Vishali, working as a Senior Resident at SMBT Medical College, Nasik. We both will be the screen coordinators for today's session. So today, we will have a very important topic, that is antepartum hemorrhage and its anesthesia management. Antepartum hemorrhage is a nightmare for the obstetrician and equally challenging for the attending anesthetist when the patient presents to the operative intervention. But before we begin, let's invoke the blessings of Ma Saraswati by playing Saraswati Vandana.
भारती तव चरणों प्रणमामः नाद ब्रह्ममयि जय भागेश्वरि नाद ब्रह्ममयि जय भागेश्वरि शरणं ते गच्छामः जय जय हे भगवति सुरभारति तव चरणों
Now to get the wheel rolling, I would like to invite our honorary secretary of ISA and our favorite, Dr. Sukhminder Bajwa sir, to put a light on this topic.
Thank you, Dr. Himani. Rather than me putting the light, I think the entire light will be put by Dr. Bhaskar and Dr. Vanilla and Dr. Vinitha today, because the topic is very important right from your first year of postgraduate career, then even when you go to the practice or even you to the institutions. These type of cases, when they come, I think your adrenaline stores, you have to make it full somehow, because these cases are very difficult to manage. The difficulty variation can be from two extremes also. So such cases actually they pose many challenges. I think rather than me dwelling upon those challenges, let's go to the class. I think Vinitha must have prepared very well, and she is ready to answer all the queries of the audience also today. So I'd like to hand over the stage back to Dr. Himani and Dr. Vishali. Please carry forward.
Thank you, sir. Moving forward, I request Dr. Vishali to introduce the faculties for today's session.
Thank you, ma'am. Good evening, everyone. So, I am honored today to introduce two most eminent personalities in the field of anesthesia. Our first guest faculty for today is Dr. Bhaskaran sir. Sir, is the screen visible, sir?
No, just gone. It was visible previously.
Just one second. Now it's visible, sir?
Make it full screen. Yeah, visible now.
Yes, sir. Okay. So I am very happy to introduce Dr. Bhaskaran sir. Sir really needs no introduction. Sir has completed his MD anesthesia from AIIMS New Delhi in 1980. In 1980, after that, he joined Southern Railway Hospital as consultant anesthetist at Perambur, Chennai, and he worked there from 1980 to 1988. Sir then joined Apollo Hospital in 1988 and has been working as the head of the department and chief cardiac anesthetist from 2004 till now. Sir has received Lifetime Achievement Awards 2 times, once from MGR Medical University in 2012 and once from EACTA in 2023. He has 50 plus journals and editorials in his name. And this is all just a tip of the iceberg of the work sir has been doing in anesthesia. I welcome you, sir. Our second guest faculty today is Dr. R. Vanilla ma'am. This evening won't be enough if I start mentioning all the achievements ma'am has in her name. in detail. Ma'am completed her MBBS from GMC Chennai. She did her FRCA in 2006 from Royal College of Anesthesia in UK and PGC TCP in Liverpool. Ma'am has a FHAE degree from London, UK in 2008. Ma'am has an entry fellowship in difficult airway. She is currently working as a senior consultant at Apollo Women's Hospital, Chennai. She has worked as a consultant anesthesiologist in Kovai Hospital and Apollo Main Hospital. She was the lead consultant at Apollo Cradle Women's Hospital and has helped setting up emergency medical cover and level 2 critical care unit. She has a special interest in head and neck surgeries. She is a ACLS instructor globally in UK since 2008 and she is a reviewer and editor in Indian Journal of Anesthesia. Ma'am has been invited as a faculty pan globally in all leading platforms for speaking. Ma'am has 70 plus journals in her name and editorials. I welcome you, ma'am. I now request the faculties to introduce their PG student.
Yes, sir. I will. Thank you. Thank you very much for the lovely introduction. And we'll now move over to the main session. I now introduce Seram Vinita. Dr. Seram Vinita finished her UG from a leading institution, MMC Chennai, and is now being our dependent candidate in Apollo, a very keen student, and she's now in final year. She's eager to go ahead with her presentation now.
Thank you, ma'am.
Vinita, before you start, there's a small request for everybody. Before we start, please just mute all. Everybody should mute their Zoom meeting and your microphone should be muted, and please don't start the video to avoid the interruptions. If you have any queries, you can type it in the chat box and all of those will be addressed in the end.
Can I go ahead, ma'am?
Yeah, please. Vanita, please.
Okay. Yes. Good evening, everyone. Thank you, everyone, for joining. First, I would like to thank ISA National and Dr. Vanilla ma'am and Dr. Bhaskar sir for giving me this opportunity and helping me throughout. So we'll go ahead. Today, we'll be having a small discussion about antepartum hemorrhage and abruptio placenta, a case presentation, what is the presentation and management. So this is a 36-year-old Mrs. Nalini from Chennai, who is a school teacher by profession, gravida 2 para 1 live 1, booked and immunized the last menstrual period on 2nd June 2023 and expected date of delivery on 9th March 2024 at 35 weeks of gestation, came with chief complaints of bleeding per vaginum and decreased perception of fetal movements. History of presenting illness. She complains of bleeding per vaginum for past 1 hour. She has passed few clots, has one sanitary pad soaked with blood, and is associated with pain. She has no history of any fall, trauma, travel, or coitus history. No history of similar bleeding episodes in this pregnancy. Decreased perception in the fetal movements she has been feeling for the past half an hour. History of present pregnancy. In the first trimester, she conceived spontaneously and the pregnancy was confirmed at 6 weeks of gestation. She is booked and immunized. No history of excessive vomiting, fever with rash, exposure to radiation, increased frequency of micturition, bleeding per vaginum or vaginal discharge. History of intake of folic acid tablet is present. Quickening was felt at 18 weeks. Immunized and regular consumption of iron and calcium tablets is present. No history of bleeding per vaginum, headache, swelling of legs or blurring of vision. No history of abdominal pain or bleeding PV in the third trimester, or no history of decreased perception of fetal movements any prior. All the scans and investigations in all the 3 trimesters were found to be normal. And the total weight gain of her in this pregnancy is 12 kgs. Menstrual history, she attained menarche at the age of 14 years, regular cycles 3/30 and not associated with pain or clots. Marital history, non-consanguineous marriage, married for 10 years. Past obstetric history, she conceived spontaneously. All the 3 trimesters were uneventful. She had a term normal vaginal delivery, and the baby at present is 7 years of age. Past history, no history suggestive of diabetes mellitus, systemic hypertension, thyroid disorders, asthma, tuberculosis, or any other heart diseases. No history of any surgeries in the past, no history of blood transfusion. Summary of the history, a 36-year-old, gravida 2, para 2, live 1 at 35 weeks of gestation with no known comorbidities, with sudden onset abdominal pain and bleeding per vaginum, has come for further management. General examination, patient is conscious, oriented, afebrile, pallor is present, no icterus cyanosis clubbing, no lymphadenopathy or pedal edema, thyroid, breast and spine examination normal. A vital examination, heart rate is 110 per minute, regular in rhythm, low volume, felt in all peripheral sites, BP 90/50 mmHg in left upper limb in supine position, respiratory rate 22 per minute, height 158 centimeter, weight of 70 kg, and a BMI of 28 kg per meter square. Obstetric examination, inspection, abdomen is longitudinally enlarged, umbilicus is in midline, no scar sinuses or abdominal wall edema. Palpation, patient examined in supine position with knee flexed, uterus per abdomen at 36 weeks of gestation, diffuse tenderness present in the lower abdomen, fetal heart rate present, auscultation, fetal heart rate 140 per minute. Cardiovascular system, first and second heart sound heard, no murmurs. Respiratory system, normal vesicular breath sounds heard, no added sounds. Central nervous system, no focal neurological deficit was present. Airway examination, modified Malampati score grade 2, interincisor distance more than 3 finger breadth, thyromental distance was adequate, no loose tooth or dentures, neck movements were adequate. Summary, 36-year-old, gravida 2, para 2, live 1 at 35 weeks of gestation with no known comorbidities and sudden onset of abdominal pain, bleeding per vaginum, and decreased fetal movements. On examination, she has pallor with a low BP of 90/50 mmHg, heart rate of 110 per minute, and tender abdomen. Diagnosis, a 36-year-old, gravida 2, para 2, live 1 at 35 weeks of gestation with a single live fetus in longitudinal lie in cephalic presentation has come with antepartum hemorrhage, probably due to abruptio placenta.
Okay. May I interrupt there? Thank you, Vinita, for the case presentation. So, so you went through the summary, and how did you get to this diagnosis that this is what is the diagnostic feature of antepartum hemorrhage due to abruption placenta here?
When it comes in history wise, she's having bleeding and it is painful. Tense abdomen is there, and there is also a decrease in fetal heart rate. And in the previous scans, we have been seeing that there were no abnormalities seen. So it was two main likelihood diagnosis when it comes to antepartum hemorrhage would be abruptio placenta and placenta previa. And so if there was any low-lying placenta, it might have been picked up in previous ultrasound scans. All those scans were normal. There was no history suggestive of any low-lying placenta. And it is a painful bleeding and no history of any warning hemorrhages, which is more in favor of placenta previa. She does not have any history of bleeding apart from this. This is the first episode. All this and also it is multiparity. All this more guide us towards it being an abruptio placenta rather than placenta previa.
Okay. Okay, that is fine. So if it was any other scan, so although scan doesn't always pick up placenta previa, but it would have been more likely to think of it. But yes, this looks more like a abruption placenta. Anything else you would like to ask in history at this point of time? I think no history of trauma and no history of
No
any
history.
raised blood pressure. I think considering she's a
Uh,
36-year-old and a long gap between the first pregnancy and the second, you have to also ask for any history of headaches, any recent change in blood pressure, any medicines that she's taking. So that would give us an idea whether she's going into the other spectrum of diseases that has a higher like hypertensive disorders, where you may
yes.
have an abruption as well. So, but that a negative history is also significant.
Yes. Okay.
Sir, would you like to add something here, Bhaskar sir? No. Okay, so now how would you, so now that you've come to the diagnosis, what would be your first step of next step now? Now that you are the anesthetist on call and you've got this lady in labor room and you're called to assess and you have assessed, and what is the next step now?
Sorry,
Uh,
Vanilla, my mic was muted. Sorry, I just unmuted it.
Okay, sir, yeah.
Okay. The important thing is what is the fetal heart rate, and then that is how the obstetrician will be more concerned and things that is going down the hill. So we will be called, and then we have to act according to that. So we will be interested to know the fetal heart rate. And if it is really drastically coming down, obviously the patient has been already shifted to the theater, and then by the time you reach there. So that is how usually our obstetric emergencies are done. So,
Yes.
so then you have very less time to go in such a detail. But this patient will allow you to elicit history and go through this more for discussion. But from the practical point of view, we will always have a complete picture. The obstetrician will be there to give us all this background of the data, how the antenatal period was, and what is the fetal heart sound, and how it has deteriorated, or what is the concern to do as early as possible. So that's going to decide your future plan.
Yes, absolutely. So how the condition of the mother and condition of the baby, both of which will decide how we are going to deliver the baby and what is your role in that process. Okay, so what is the next step now? So I think that would have been your next step, right?
Now that we have a brief history and we know have a rough picture with the BP and knowing the vitals, first I would say the mother is in moderate shock and we would like to resuscitate, and we'll first go with resuscitation of the mother following the ABCD protocol. So first giving her a high flow oxygen with the face mask, 10 to 15 liters of 100% O2, and then I would secure 2 large bore IV cannulas. And when I'm securing a large bore IV cannula, I'll also like to draw blood samples. And these blood tests I would give to the laboratory and also bedside blood tests, because we know it will be an emergency situation or it can be. And then we would have to have a bedside investigations, not just rely only on the laboratory investigations for the report. So I would like to take blood samples. I will send an arterial blood gas analysis. I'll send for CBC, including hemoglobin, hematocrit, platelet count, urea creatinine. Along with that, I'll send for coagulation profile, which should include a prothrombin time, INR ratio, activated partial thromboplastin time, fibrinogen, serum fibrinogen levels, blood grouping, cross-matching, grouping typing and cross-matching. And when I'm doing this, I'll also ask them to catheterize the patient. I'd like to have a look on the urine output. And once I send the blood test, I will start IV fluids for the patient. First, I'll start with crystalloids.
Yes, hang on. So as you get your ABCDE done, the airway is secure, the patient is breathing at 28, maintaining airway, maintaining the breathing, circulation is a little low, so you start IV fluids and you're going to start, tell me your choice. You send off an ABG, you send off the bloods. So why would you send a complete blood count and coagulopathy profile for this patient?
First, because she is bleeding, we would like to have a baseline. What is the current picture? What is the hemoglobin? What is the platelet count? Because we don't know like where is she exactly on the coagulation pathway. There is a high risk that she could be on an altered coagulation mechanism where she could be going into a DIC or a coagulopathic picture, disseminated intravascular coagulation. So we don't know what is her exact coagulation parameters, and she's bleeding, so we would definitely have to replace it. And to know what we are replacing, we should know what we are dealing with, to know have a baseline. If a coagulation is fine, which part of a coagulation is affected.
Okay.
To know that, I would like to have this, ma'am.
Okay, so you'd like both the PT-APTT and INR ratio as well as the thrombocytopenia.
Serum
So
fat.
during her
Yes.
pregnancy, her hemoglobin was 12, platelets were 306,000 into 10 power 8 per liter, and LFTs, renal functions and coagulation was normal, serology negative. Her basic booking bloods and the second trimester bloods were normal. Okay, so now you send off the blood gas and comes back in the blood gas. You also have the hematinics, and hemoglobin shows as 7. Base deficit is about minus 16. Patient also has a pH of 7.2. She's maintaining her oxygenation. CO2 is around 28. Okay. So as they put the catheter, you see about 10 ml to 20 ml coming through very slowly of high colored urine, and patient is very thirsty.
This was a patient is in shock, ma'am. There are different levels of shock. She is in shock because her vitals are unstable. Her BP is low. She has tachycardia. And now with the picture where she has acidosis, as I said, pH is low with more of base deficit. We know her circulation is being affected. Her end organ perfusion is being affected. So definitely we would like to give rush fluids, give crystalloids. And at the same time, since I have asked for blood grouping and cross typing and matching, I would ask for blood reservation also at this point.
Okay.
Knowing it is 7, initially it was 12. So definitely she has lost a significant amount of blood. So at least I'll ask for 3 to 4 PRBCs to be reserved.
Okay.
And
you heard about yeah. So what does this?
Yes,
how do you want the blood bank? Is there anybody else you would like to call at this stage, or would you like
yes,
to?
ma'am. The first when I see this, I'll call for help. I'll call for the senior obstetrician. I'll call for senior obstetrician, and then I will call the blood bank. I'll inform that there is a patient like
your
this. I'm
senior
asked.
anesthetist. Your senior
Yes, I'm
anesthetist.
senior anesthetist. I'll call my senior consultant anesthetist also, ma'am.
Okay.
I'll call for help. I'll tell them what is the patient history. I'll call them for help, and then I'll inform the blood bank.
Yes.
That this is the situation. I'm sending bloods for this patient, and I might
What is it that
require.
you would like to request for?
I will tell them that it might be a massive transfusion protocol might be required for this patient. So we need to be ready for that when and where if that is required. So I
you
will
will be
give them a
reserving,
heads
right?
up.
So you
Yes,
have
ma'am,
to
I'll reserve them. I'll reserve them. I'll reserve, ask for massive transfusion protocol to be kept in hand for this patient, ma'am.
Okay. So have you got slides on all of these? So based on would you like to go ahead with your presentation up until now? So now that you're going to prepare the patient, how are you going to prepare this patient? You've informed your seniors, you've got your bloods booked, and how many units of PRBC and FFP? What is it that you're asking the blood bank officer for?
I'm asking for 4 PRC, 4 FFP, 4 platelets, and 10 cryoprecipitate at this moment, ma'am. I'll ask. And also inform that we might require more and to have a massive transfusion protocol in hand.
Initiated. Okay.
Yes,
so
ma'am.
send the samples off. In case there is a delay in blood and the patient decompensate at any point of time, what is indicated for this patient?
Apart from apart from crystalloids, if a cross matching and typing is not there, I would request them to give a O negative PRBC, ma'am.
If the patient compensates and you have cross
yes, ma'am.
crystalloids.
Yes, ma'am. If I don't get a typed and matched blood, I'll ask for a O negative blood, ma'am.
Okay, so as we are discussing and calling for help and arranging bloods, the obstetric registrar tells you that the patient has the heart rate is showing late decelerations and she does not like the way the CTG is, and the mother's blood pressure is now 80/50. You have already given 2 pints of ringolactate solution, which is your first choice that you mentioned, and the urine output has not changed and she's looking more paler. So what is the next immediate step? What is the plan now? All the seniors have arrived.
We will shift her to OT, ma'am. Next is shifting to OT, preparing the OT, shifting to OT, and going ahead with the emergency cesarean section.
Okay. Anybody else to be called in terms of the baby?
Yes, ma'am. Once we are planning, I'll call the neonatologist.
You will ask the labor room to call for the neonatologist.
Call for the neonatologist. Yes,
Okay.
ma'am.
Okay. So you're going to go ahead with the presentation until preparation for theta. Do you want to proceed with the PPT? What do you have next?
Sure, ma'am. Is it visible, ma'am?
It's visible, yeah.
Yeah, sure. So now we have had a rough picture of the idea of this patient with a summary and diagnosis. So just to have an idea why this is important, antepartum hemorrhage, basic definition is any bleeding from or into the genital tract after a period of viability. In India, the period of viability is 28 weeks of gestation. Previously, the perinatal mortality for antepartum hemorrhage was as high as 80%, but the recent data shows the perinatal mortality for abruptio placenta comes around 12% and placenta previa to be around 2 to 3%. And this itself is also a very big number, not as high as 80, but still it's a very big number, and hence this topic becomes very important. So, if you're planning to have management of obstetric hemorrhage, it's good to have an idea of how we define hemorrhages in obstetrics. What is a minor hemorrhage? What's a major hemorrhage and massive hemorrhage? A massive hemorrhage is more than 1000 ml with any signs of clinical shock. There's something called massive obstetric hemorrhage definition. In this, it comes as when it is more than 1500 ml, sudden loss, or if it is more than 3000 ml in 3 hours, or if it is 150 ml per minute for 20 minutes, or if you're requiring 4 packs of PRBCs, these all can be classified as massive obstetric hemorrhage. So as we already discussed that major causes of antepartum hemorrhage would be abruptio placenta and placenta previa. Abruptio placenta is more of a clinical diagnosis. There is no laboratory test which can tell this is abruptio placenta. Major differentiating features between abruptio and placenta, as we discussed, would be most commonly in placenta previa, it would be a painless bleeding where there'll be no inciting factors, no history of trauma, fall, or high BP or anything. Whereas all this can be present in abruptio placenta. And placenta previa, they can have recurrent bleeding. They can give history of spotting in this pregnancy. I had multiple spotting history, bleeding history. So those are called as warning hemorrhages, but this is not present in abruptio placenta. And the other causes of antepartum hemorrhage would be vasa previa. These are less common: circumvallate placenta, rupture of marginal sinus, preterm labor, uterine rupture, or any coincidental factors like cervical polyp, erosion, genital infections. These are some of the guidelines that were given by recent RCOG, which says that APH, antepartum hemorrhage, has a heterogeneous pathophysiology and cannot reliably be predicted. And a woman should be advised and encouraged and helped to change modifiable risk factors. And that APH is associated with maternal and perinatal morbidity and mortality. Therefore, all clinicians who are managing women with APH, which includes us anesthetists, should be aware of these potential consequences. And whenever you are suspecting such a patient or a history, a multidisciplinary team should be involved, which includes obstetric staff and should have immediate access to laboratory services, operation theater, neonatal, anesthetic services should be there immediately. So, coming to a rough definition of what is abruptio placenta, it is a premature separation of placenta And this premature separation means there is separation of placenta before the delivery of the baby. And it complicates around 0.5 to 1% of pregnancy. Coming to risk factors of abruptio placenta, the most important predictive factor is their history of abruption in a previous pregnancy. Apart from this, there are other risk factors which can be either obstetric or maternal or any other history. So in obstetric, the important ones would be an advanced maternal age, multiparity, history of any preeclampsia, premature rupture of membranes, chorioamnionitis, and the maternal comorbidities will include any history of hypertension, acute or chronic respiratory illness, substance abuse, or any tobacco abuse, and direct or indirect trauma. So, in most of the abruptio placenta, either there'll be a history of abruption previous pregnancy, or they can give some history of trauma, which could be direct or indirect. It may be a trivial trauma or a actual big trauma. The classical symptoms would be vaginal bleeding, uterine tenderness, and increased uterine activity. What happens is when there is this premature separation of placenta, there is bleeding from the spiral arterioles from the decidua basalis, and this bleeding can either come out, which is a revealed variety of abruptio, or it can not be revealed out, which is a concealed variety, which is more dangerous than a revealed variety. Because when it is a concealed abruptio, we tend to have a gross underestimation of the hypovolemia and the blood loss that has occurred. And apart from that, when there is this concealed blood loss, bleeding, so it forms a retroplacental clot. And this bleeding, which will keep on increasing, increases the pressure in the intervillous spaces. And it is this increased pressure which causes in release of thromboplastin. And this thromboplastin is the culprit here in abruptio placenta. This thromboplastin, it acts as a uterotonic. So it increases the tone of the uterus. So it can lead to tender abdomen. It also can trigger preterm labor. And this thromboplastin is responsible for development of disseminated intravascular coagulation, that is DIC. So it is not just the bleeding which is responsible for all the symptoms and complications that occur in abruptio. Specifically, it is this release of thromboplastin. So in placenta previa, this thing is not there. There is no presence of clot or increased production of thromboplastin, and hence occurrence of DIC is less in placenta previa when compared to abruptio. And as we discussed, the diagnosis is primary clinical. Ultrasound is highly specific for abruptio placenta, but it is not sensitive. And hence you cannot just rely on a per-abdominal ultrasound. So we have reached where we come to the management.
Yeah, so that's good. So now we spoke about resuscitation, and what are your goals of pre-optimization in the minimal time that you have while you've seen the patient and now you move to OT and you're going to get the theater ready. So and we've said crystalloids, and what next? So
We have given crystalloids, we'll catheterize the patient, watch for urine output, ma'am. And along with that, I would also give her aspiration prophylaxis at this moment. Now that we have decided that we are going to take her to the theater, I would give her pantoprazole 40 mg IV, metoclopramide 10 mg IV, and ondansetron 4 mg IV.
okay,
And keep her on oxygen and give her a lateral tilt.
okay, left lateral.
And at the left lateral tilt. And at the same time, I will prepare my theater. I've called for help. I'll ask for my senior anesthetist to be there.
Yes.
I'll inform the blood bank that now we are taking this patient to the theater. So we'll require blood.
Yeah. So
And
what will you explain to the patient and the attender?
explaining to the patient, we have to tell that what is happening. At present, the baby is fine. We can see the fetal heart rate is present. At present, but then there are
Yeah, go on. So you say that there is a compromise, there is a bleed.
There is bleed, there is
For an emergency.
fetal heart rate is present, but then some amount of fetal distress, fetal compromise is there. And to make sure that the compromise on the mother's side and the baby side both improves, the best mode of action at this moment is to deliver the baby as soon as possible, because that is what will reduce the complications that are happening to the mother and the baby. So
Okay,
we
so
have to
that's being
explain
done
to
by
her.
the obstetrician. You're going to tell
Mm.
them the anesthetic side, right? So what are you going to tell them?
I'm going to explain to her that I'm going to give her a general anesthesia.
And why?
I will tell her that cesarean section can be done under regional and general anesthesia, but for her at this moment, I would prefer to go for a general anesthesia rather than giving her an injection in the back, because I'm not sure if I'm given injection in the back, what is her bleeding and all. She might have a bleeding in the back when I inject there, and so it would be better to go for a general anesthesia.
So
It
it
is
says this
safer.
is an emergency, life-threatening
Um,
situation, and therefore
hmm.
we'll go ahead and give a general anesthesia.
It is safer for her and the baby.
Yeah. Safer for the baby. So what, and you will get a informed consent form, because she may
Informed
need a blood transfusion, she may need prolonged ICU stay, she may need more products, and the consequences of them are also to be present. Okay, so those are the consent details, and then we wheel into theater. How do you prepare? What are the things you get ready for general anesthesia for this lady who's 35-70 kg, come in abruption with blood loss, hemodynamically potentially unstable? And what are the things you're getting ready?
I will prepare my theater. I'll check my machine.
Yes.
I'll load emergency drugs, which will include phenylephrine, ephedrine, atropine, glycopyrrolate. I'll load general anesthesia drugs for this patient. I will calculate based on her weight and I'll load it and keep. I will keep crystalloids, colloids ready. I'll ask for the blood to come. I'll ask at least 2 PRBCs, 2 FFP in hand, was to be shifted as soon as possible from the blood bank. And
Okay.
I'll keep a patient warmer, fluid warmer ready.
Okay.
And I'll ask 2 people for help, ma'am. 1 person to give drugs and 1 person to give me cricoid pressure.
Okay.
And keep suction ready.
Mhm.
And I'll also keep noradrenaline, inotrope drugs also loaded standby.
Okay, so apart from
And
the
any
large bore lines on the hand,
for IV. Yes,
would you
ma'am.
like anything else?
I would keep, along with the large bore IV cannulas that we have already secured, I would like to keep a standby if we require any central venous access or arterial access. If required, I'll just keep it in the standby.
Okay. So in EJV line might always be useful, because for large volume as well as inotrope insertion. And
Yes, okay.
particularly for somebody with a moderate level of shock, an arterial line would be a good idea to have. Okay.
Yes.
Okay, then. So what are the drugs that you're going to use for general anesthesia?
In this patient, I would give a general anesthesia with rapid sequence induction and intubation, ma'am. So I would like to give thiopentone sodium 250 mg, followed by succinylcholine 100 mg IV. And then I will intubate with a smaller sized cuffed 6.5 endotracheal tube. And once the patient is awake, I'll ask the other helping person to give a mild pressure, cricoid pressure. And once the patient is under, to increase the pressure. And after I have secured a endotracheal tube and I have checked the position of the endotracheal tube by auscultation and by ETCO2 monitoring, then I'll ask them to go ahead with the surgery. Before I am inducing the patient, I'll ask the surgeons to be ready to paint and drape and to be ready. And then only I'll start inducing, ma'am.
Yeah. So
And
you
once
the surgeon is ready,
the
neonatologist,
neonatologist is ready. Yes, ma'am.
painted, draped, so we don't waste much time on the other.
Yes,
So
ma'am.
with regards to your choice of induction agent, you did mention thio and succinylcholine, which is usually the standard drug of choice that we have used for many years in obstetrics. But any particular reason that any other drug could be used in this particular patient, considering she is in hemodynamic shock? You can use any drug, can be safely used in the hands of a safe anesthetist as long as you titrate it to the patient. But is there any other choice that can be used?
Ketamine also can be used, ma'am, for induction. Ketamine is also a viable option
You
since
use
she's
a
in shock.
hemodynamically stable agent, so you don't compromise further the already existing hypotension and hypokalemia. So you want to have a cardiostable anesthesia that can improvise. So there are many units and many anesthetists who may prefer to use ketamine for this patient as an induction agent along with succinylcholine. And you have to be wary about the secretions. May add glycopyrrolate beforehand.
Okay, ma'am. Okay, ma'am.
Okay. A rapid sequence. You've secured the tube and the surgeons start the procedure. And yes, so once surgery begins and then they deliver the baby comes out with a low Apgar and given to the neonatologist, and they proceed with the neonatal resuscitation. And the mother has about a liter of blood in the abdomen, and the blood pressure starts drifting down.
At this moment, now if I have blood, I'll start giving blood products, ma'am. I've asked
What
for
is it that
packed
you will
RB.
be giving immediately after delivery?
Once the baby is delivered, I will give oxytocin, ma'am, uterotonics. My uterotonic of choice will be oxytocin, 5 international units IV bolus, followed by 15 international units in 500 ml NS over 3 to 4 hours.
Yeah.
And I give
anything else you'll be giving. You'll have added blood. By now the blood has arrived, so you start doing 2 units of
the blood
and FFP simultaneously. Anything else?
Yes, ma'am.
Yeah. So while you're filling the volume, what additional drug might be useful in a hemodynamically compromised patient? Because you want to maintain the heart rate, you want to make sure the volume is filled up, so you maintain the cardiac output. So what inotrope would be the drug of choice in pregnant women in obstetric hemorrhages?
Phenylephrine can be used. Aliquots of phenylephrine I would use, ma'am. 25 mics start with aliquots and can be titrated. And I can start on noradrenaline. If it is still not being maintained, then I would go for an noradrenaline infusion, ma'am.
So, yes, so that is why having an axis in the neck
Okay.
closer to the heart is above the level of diaphragm is always useful in obstetric patients because there is no time and space during surgery. Okay, so we get EGV axis or internal jugular depending on time and suitability, and that is why having it before would help you to give volume bolus as well as titrate the noradrenaline infusion. Okay, so what is the normal concentrations you're aware?
Of what, ma'am? Sorry.
Noradrenaline. So you ask your technician to get the noradrenaline ready. Okay.
Yes,
so you titrate the blood pressure. So what are your targets of transfusion? How do you maintain the hemodynamics? How do you know what you're doing is right until the surgeon sorts out the uterus? What are the risks of abruption right now? So patients had a bleeding. They've taken the baby. They are suturing the uterus. What are the things that are happening right now?
She still has, if she has bleeding, so important would be here if she can go into uterine atony or going into coagulopathy. These two would be my major concerns at this moment, ma'am. So once the surgeon team, they would be knowing if the uterus is flabby or if the uterus tone is good, because I've started giving the first line of uterotonics. Oxytocin has already been given. So that would be one side.
Can you give a little bit more? So their tone is not entirely great and they have evacuated all the blood and they're beginning to do compression sutures because and they ask you to give the second line of drug, which will be?
Methyl ergometrin, ma'am.
What other common drugs do we use? Methergine and?
Methyl ergometrin or carboprost, which is prostaglandin F2 alpha, which can also be used, ma'am.
Yes.
Or
so mesoprostaglandin, wait for 5 to 10 minutes, and if that doesn't work, we would go ahead to give prostaglandin. What is the dose of prostaglandin, carboprost that we use?
250 mics, ma'am.
Okay.
0.25 mg. Can be repeated up to 8 doses at 15 minutes of intervals. Up to 2 mg.
A bolus of Cinto, continue the infusion, a bolus of Methergine, and following which, if it is still atonic, you give carboprost, and that can be repeated every 15 minutes. What is it that you would be cautious about which patients when you're going to give carbaprost or methogen?
For methyl ergometrin, any patients with who have a history of hypertension, preeclampsia, or any coronary artery disease, it is cautious not to give. It causes severe systemic vasoconstriction and can cause severe coronary vasospasm or pulmonary artery vasospasm. And for prostaglandins, any patients with a history of asthma or reactive airway diseases or pulmonary artery hypertension, it is better not to use this, ma'am.
Or you would give it IM, intramuscular, and you would watch for such symptoms. So you want to make sure the bronchodilators are available, because these are life-saving drugs, and in atonic uterus and obstetric hemorrhage situation, these are life-saving. So we will probably, but you have to use it with caution and with the knowledge. So carbaprost is there in the protocol, and we use it on a regular basis, and we have to be cautious and vigilant about to look out for complications. Yeah. So you've given that, you titrated the blood pressure is coming up. How else would you know that your resuscitation is successful? The surgeon says, okay, the uterus is becoming a little bit more better now. They've got the compression sutures on, and they're getting extra hemostasis around in the peritoneum and in the rectus. What else would give you an idea? Blood pressure is 80-60 now. Heart rate is about 120 per minute.
Urine output, ma'am, and we can do a blood gas analysis. I can send an ABG. We can see what is the trend, how is the acidosis, what is the pH, the lactate level, base excess, what is the hematocrit in that. We can do that, and that will also give us.
Completed 4 of FFP and 4 of platelets, and there's about a liter of blood in the. How would you assess how much blood loss has actually happened? Because you've already given 4 of FFP, 4 of PRBC. How much more is the next question? So how would you know? Now you've sent hemoglobin to the ABG. Urine output is about 100 ml so far since she's come to hospital, and the color is getting slightly better. Okay, and you now have you sent the sample off, and what is the quantitative assessment of blood loss in theta? QBL.
Quantitative assessment, that is first thing is we will measure the blood in the suction tubings, ma'am, the suction canister that we have, and in that we have to keep in mind if they have used any wash or anything, or whether there's amniotic fluid, if that is separate or not, we have to keep that into account. Apart from that, blood in the drapes, in the pads, that all can be weighed, or we can do estimation where the smaller pad is 40 ml fully soaked, bigger pad is 60 ml fully soaked. If we do not have the weighing pads, we can. The ideal way would be to weigh a dry pad and then a wet, fully soaked pad, and then see how much blood is there. And by conversion factor for our ease, we can use it 1 mg increase in weight is 1 ml of blood.
Correct. So based on that, you get an estimate of about 1.5 liters loss, and maybe about 200 to 300 ml would have been amniotic fluid, but everything else is blood and clots. But you've given 4, and the hemoglobin comes back as 6. And the hematocrit is only showing 19, pH is 7.19, base deficit is -12, and your clotting comes back, the one that you sent in from the labor room before wheeling into theta. INR is 1.6, and fibrinogen is 120.
Now with this, we know that we have given blood, but still her conditions have not improved as much as we would have wanted. And with this coagulation, we know that she's somewhere in an abnormal coagulation pathway. So I like to give FFP, cryoprecipitate, and give fibrinogen.
Okay. So why would you want to give FFP? So you've given 4. Fibrinogen is 120, and you've asked for cryo. You've reserved cryo, right? You told us that you've reserved cryo before.
Yes, ma'am.
What is the purpose of giving multiple factors in the blood transfusion? So PRBC is going to give you blood cells, red blood cells.
Yes,
so FFP, what is the point of transfusing FFP?
Ma'am, PRBC will give us RBCs, as you said, ma'am. And then a fresh frozen plasma gives us coagulation factors, and some amount of fibrinogen is also there in a fresh frozen plasma. Cryoprecipitate is nothing but it is a pool of high molecular weight proteins from the plasma. So that is more rich in fibrinogen, and more rich in factor 8, factor 13, von Willebrand factor, and fibronectin.
Yeah.
So if you want to replace coagulation factors, especially fibrinogen, cryoprecipitate would be better than fresh frozen plasma.
Yeah. Any
It has
other
more
details?
specific
What is the volume of each bag of FFP and what is the volume of each bag of cryo? And how is that significant when you're doing a massive transfusion in a bleeding DIC
for
patient?
yes, ma'am. For fresh frozen plasma, it is nearly 250 ml per bag, and cryo is 10 to 15 ml, or maybe around 20 ml. So if we are going towards a massive transfusion protocol, with the more volume, there is more chances of causing transfusion related acute lung injury and transfusion associated cardiac overload. So when we are replacing the similar coagulation factors that we want with the less volume, that is an added advantage that we get with cryoprecipitate. We don't
Yeah.
have to give that much volume.
So 10 units of cryo amounts to about 100 to 200 ml, depending on the volume.
Mhm.
And each 10 ml will have about how much of fibrinogen?
In that one bag has nearly 200 mg of fibrinogen,
Yeah.
and that each bag will increase by around 7 to 10 mg per deciliter in the patient's body.
Yeah. So why is it that fibrinogen is significant? And is there any other alternative? So you have mentioned to us that the massive transfusion of FFP, because of the sheer volume and the cryo, I mean, we all know that blood products have a risk of allergy tendency as well. They can stimulate an ARDS-like picture as well as cardiac overload. Is there an alternative that is available to us, and is that feasible to use?
We have fibrinogen concentrates available, ma'am, which is a commercial preparation of fibrinogen, which is produced by pooled plasma. That is available, and the advantages of using a commercially available fibrinogen concentrate is that one is, as we mentioned, it is low volume. It is really less volume, and it is more accurate dosing can be given, and it has less chances of causing allergic reactions, chance spread of infections than transfused from cryo or FFP. And another thing is the rapidity. If you have available of cryo this fibrinogen concentrates, we don't have to wait for cross matching and typing. The rapidity of it is another added advantage. So
Yeah.
we do have fibrinogen concentrate available, ma'am, commercially.
So I think it's becoming more common and noted to use fibrinogen concentrates as early as from the time of start. If you had known that fibrinogen is 120, because ideally pregnant women should have greater than 200 to 400, because that they are normally in a hyperfibrinogenemic state. That is the normal physiology of pregnancy. So if 120 is actually very low for a pregnant woman to make up for the clotting mechanism, and that is why we try to keep it above 200. So fibrinogen concentrates, the one thing that you mentioned, yes, it's low volume, it's lyophilized powder, it can be available. It may save the time waiting for cross-match blood, especially if you're not in a unit where blood bank is closely available and it has to come 1 or 2 hours away, because it has to be thawed and then brought. But it can be allergenic. Okay, so that is the
Yes,
one
ma'am.
caution that you have to be careful about, not to repeat if she's allergic. They do have, because they are lyophilized from pooled plasma. So that you have to be wary about. Okay, so these are the other alternatives, and studies across the world have shown that this has saved a lot of blood transfusions and saved a lot of patients from other complications like TRALI, because they're already in DIC, especially in abruption patients and amniotic fluid embolism patients, where this has been a lifesaver. The earlier you give, the better. So what other tests you could be doing for this patient in the bedside if you are in a tertiary unit where other bedside tests, point of care testing is available?
Bedside thromboelastography take can be done, ma'am. Bedside take. It is a point of care bedside viscoelastic assay, which gives a picture of the total hemostatic process that is happening in the patient. So it will tell us about the function of the platelets, clot formation, fibrinogen function, fibrinolysis function, everything in a very quick way. So in that we can see which part is affected, and we can give a more targeted treatment.
Yes. So I think we are using, although our unit we don't have, but if you are in a tertiary unit where there is availability of tech, that would be a very valid tool, because the lapse between sending the blood sample and on-table changes and then the, dynamic changes that happen during surgery, we may lose an hour or two, and that may make a huge difference in the outcome of the mother and the baby. So if we have tech, that would be or rotem, either of them would be
Decorate, ma'am.
in the absence of either of these, what we use is bedside BTCT that helps us to judge whether the BTCT is prolonged, and we send the sample off and work on the provisional protocol that we have mentioned so far. So your patient is successfully resuscitated, the blood pressure starts coming up and you start weaning down the noradrenaline. The arterial line does not have a swing. Chest is clear. You're maintaining on 50%. What MAC would you have maintained for this hemodynamically unstable patient from the beginning? Is there any?
MAC of 0.5 I would have kept a MAC of 0.5 would be enough.
And what would have
Or
been
not achieve for a 1 MAC.
agent?
Sorry, ma'am.
What would have been your gas that you used?
Inhalation anesthesia with sevoflurane, ma'am. MAC of 0.5 with air and oxygen, ma'am.
Air and oxygen. Okay, so they do have any risk of awareness, but in an unstable patient, we may want to work on that. So if you had used ketamine, that would have been a good an analgesic as well as anesthetic, but you may think of midazolam once the patient becomes
Okay.
stable. So now
Okay.
it's not closing up. They put a drain in. The urine starts coming out a little bit more. There's about 25 ml to 30 ml of clear urine. The surgeon has put a drain closing up, and now you plan for extubation. What is the criteria for extubation of a patient who came in unstable hemodynamic shock, now has undergone a surgery where you've given massive transfusion, you finish cryo, you've used a volume of fibrinogen, and patients on, is there a clinical assessment where you would stop giving any more products? So you've sent the sample and the blood, all hemostasis seems okay on table. So how do you decide whether to extubate now or wait for some more time?
In this, our major concern would be, as you mentioned, because of the transfusion, if she has any lung injuries, that would be one of the major concerns. Well, if clinically we know that the chest is clear, and if she is awake, alert, obeying commands, and we can send an ABG blood gas before extubation, we see the parameters are improving, the numbers are better, her acidosis is improving, her tissue perfusion is improving, lactates are coming down, she is having good respiratory effort, she's hemodynamically stable, not requiring any supports. Then I would like to extubate, ma'am.
Okay, that's
If
a
all
good,
these parameters are
that's
fine.
absolutely the right way to think. So, but this lady still needs a little bit of NORAD, about 8 ml per hour going. She's on 50% oxygen, but the gases still show acidosis and lactate is around 3. You're still waiting for the repeat clotting that you sent off to the lab, and the surgery is over now. So what would you do with her?
If I am unsure, I would like to keep her intubated and shift, ma'am, and then wait for the reports, see how she's responding, and then extubate, ma'am. I'll wait for some time. I'll wait and watch, give her more supportive treatments, fluids, and watch her urine output, how she's improving, and then I will.
Okay, so maybe another hour or two, you might want to just see that the bleeding settles, there is no vaginal bleeding, chest is clear, check chest X-ray, repeat blood gas, and if it's on, she's on the improving trend, neurology is good, check and then do a smooth extubation in the critical care unit, level 2 unit, and then watch her closely. So she should be received in a critical care place, and she needs to be watched closely, correct? So any other drug that we routinely use in obstetric hemorrhage and has been proven well to be used early on as soon as the bleeding starts that we have not mentioned so far? It has been widely used in
tranexamic acid, ma'am.
What is the role of tranexamic acid in antepartum hemorrhage in a patient with a potential DIC or an existing DIC?
Tranexamic acid, we know it is an antifibrinolytic. So it will help us by reducing the fibrinolysis. There are no specific ACOG or RCOG guidelines at this moment for when should be given, ma'am. But WHO has stated that tranexamic acid can be given when can as soon as possible if you see there is a bleeding mother, and it should be given within 3 hours of the delivery of the baby. And they have stressed on the fact it should be given as soon as possible. 1 gram in 10 ml fixed dose in over 10 minutes should be given. And if she restarts bleeding or the bleeding continues, you can give another 1 gram in the next 24 hours. But giving it after 3 hours has not been shown much of improvement. They do stress on giving tranexamic acid, but they also stress on giving it initially as soon as possible, not delaying giving
Within an
tranexamic
hour of
acid.
bleeding, this applies both in normal delivery situation as well as in operative delivery as well as in APH scenario. The reason why I specifically asked you if there is a difference between a atonic uterus PPH going in as opposed to antepartum hemorrhage in abruption where there is a risk of DIC. This is an antifibrinolytic drug that acts at the end of the system. So we are looking at thromboplastin affecting the initiation of the coagulation cascade, right? So that is the pathophysiology. So this will still help. It still has a role, although it can be contradictory. If the DIC is already established, it may not have a role. But if it's given early on, I think there's still a role. So it is still present, and that's what the woman trial said, and that's what many more studies over the years have seen, that obstetric hemorrhage, a single dose and then repeated half an hour later would do less harm than so we should just go ahead to using it. Making sure hypotension is managed. So yes, so this patient is successfully revived and the baby is in NICU. Anything else you would like to talk about in the management from your slides? So I think coming up to 7:30 p.m. In your slides, do you have any
Wants
more
to take a
information?
break and have some water. We can take few MCQs in between, ma'am, so that she'll
Yeah,
get some. I'll play
absolutely.
the slides. So Vinila ma'am has made MCQs for all the participants who have been listening so patiently. I'll play the slide. Just give me a second. So ma'am, we'll take the first question. Everybody is supposed to type the answers in the chat box. Ma'am, the PowerPoint presentation is visible?
Yes, ma'am.
Okay. So the question is, tranexamic acid is indicated in hemorrhage due to abruption placenta, that is in shock and DIC. You have to write the correct answer in the chat box. We'll wait for just 30 seconds, ma'am. We'll see if there are any.
Where is the choice D?
No.
Choice D is not there.
So most of the people are saying A. If you are saying B, ma'am. I'll pray the right answer, ma'am, now. So the right answer is B. That is, it should be used with caution. Ma'am, can I play the second question?
Yes, ma'am. Please, yeah.
So the second question is, with reference to placental abruption, which of the following are true? Please type the answers. I'll give you 30 seconds. So, ma'am. A. Most of them are saying
It's
A.
answer is plural, so I can give you a clue. Answer is in plural. Which of the following are true?
Only Aditi have given ma'am two options. All of
Two
them are
options.
giving
Okay.
single option answers. If you
Okay.
are saying A, if you are saying D. So I'll play the answer now. I'll put the answer. So the answer is A, C, and D.
So you just show them the options so they know the
Yes,
right
ma'am.
answer, A, C, and D.
Yes,
So
ma'am.
many of the small ones, there can be many of them. Visible hemorrhage may actually be absent in 1/5 of the patients, but your risk factors are very important. They are the ones that's going to give you a clue, especially with drug abuse, smoking, autoimmune diseases, preeclampsias. Actually, age is also an important factor. So they are the important risks. Okay, next
Ma'am,
one.
can I play the next question? We can
Yes,
take
yes.
2, 3 questions,
Yeah,
ma'am.
yeah, we can take two more. Yeah,
Yes,
please.
yes, ma'am. So the question is, management of antepartum hemorrhage includes firstly. You get 30 seconds, read the options, write the right answer in the chat box.
Okay, I think A for anesthetist, so they've got it right. A and B is also not a wrong answer. Okay.
Yes, I'll play the answer, ma'am. No? So the right answer is A. And next question, get ready. Massive transfusion protocol includes.
So this is with regards to the first request that you raise to the lab. So you may add on more later, but this is every obstetric unit and every unit where there are large major cases done should have a protocol where this, if you request a massive transfusion package, this is what it is, and it's already agreed upon, so it automatically comes.
Type the answers.
So I think somebody asked in the beginning, what is the massive transfusion protocol? So
Yes,
it could
ma'am.
be in a situation like obstetric hemorrhage, liver trauma, orthopedic trauma, cardiac cases, anyway. So each of these cases may have a defined number of units that the operating team will need. The surgeon and anesthetist would have decided with the blood bank and agreed upon. So when that is being called for, automatically the bank will release it so that you don't have to type in the computer and send form for each one of the package. It's just to save time and make things better, so everybody in the team understands what's happening. So it's 1:1:1. To begin with, it's 4:4:4. Yeah. Platelets not necessarily always involved in massive transfusion protocol. I was going to talk about it, sir. I think Dr. Bajwa or Dr. Bhaskar can mention about that. There's somebody in the answer asking about platelets.
Yeah, platelets, of course, cardiac, it is a very favorite blood product, because the patients are on antiplatelets.
Yeah.
And if you have to take it as an emergency without adequate waiting, especially antiplatelet like Brilliantum. Whereas, and again, if the patient has, you put them on cardiopulmonary bypass, then the trauma to the formed elements are always there. So then that is why the indication for, they are very particular about your protocol, including PRC, FFP, and platelets.
Yeah.
Whereas in this, in obstetric hemorrhage, as you said, maybe we can wait on platelet, but you can always do an platelet count and then
Yeah.
the initial period and then
Yeah.
transfuse it accordingly if there is an indication.
Yes, I think that's
And
the
as aggressive
current,
as a patient.
that's the current thought process. So we don't waste a lot of platelets. But yes, Dr. Bajwa wants to add.
I think if the sir is right here, the patient maybe on some time in the young ages, we have seen on this one cardiac medications, you are going antiplatelet drugs are being given. I think a better if we have a time you go for the thromboelastography. The qualitative assessment of the platelet functioning is more important in these cases rather than just quantifying the
Correct.
absolute
Absolutely.
number of platelets in these cases.
Absolutely. Yeah. So we only transfuse if it's less than 50 or 60 and wait for the tech or PTCT. Okay, Vrishali, next question, and then we can.
Yes, ma'am. I'll share the screen. Just a second. So this is the question, fibrinogen replacement, which is true. You have 30 seconds to type the answers in chat box.
I think everyone's got it. They've listened.
Almost right. Almost right.
Right. Yeah.
I'll play the answer, ma'am. So the answer is C. Next question I'll play, ma'am.
Yeah, ma'am, please. Yeah, if we have time, is that okay? Yeah.
This will
This
be the
will
last
be-
one, ma'am. This we'll take and then we'll proceed, ma'am.
Okay.
So the question is, a 34-year-old preeclampsia on labetalol 32 weeks comes with severe abdominal pain, mild bleeding PV. Heart rate is 100, BP is 90/60. Most suspected diagnosis.
Shali, one thing is missing here is regarding the obstetric side. If I take history, I think it's a primary or it's a multi, whatever. That is a very important part in this question.
Yeah. So primary.
Prime.
My fault.
And rupture uterus is more.
Rupture uterus will also be there. Yeah.
So the answer is today's topic B.
Yeah, absolutely. Primary or Gravida 2 previous LSCs would have made the diagnosis different.
So we are done with the
Thank
MCQs,
you.
ma'am.
Thank you for sharing. Yeah.
Ma'am, can we take the questions or we are proceeding
Yeah.
with the
So
presentation?
I just wanted to ask, Vinita, do you have a summary for the management at the end?
Yes, ma'am. Is it visible, ma'am?
Yeah.
So,
To skip and go to the summary, or how
yes,
many?
ma'am. Yes, ma'am.
Um,
So as we discussed, principle of management of massive antepartum hemorrhage would be a multidisciplinary team protocol. First, when you call for help, you follow the ABCD pathway and you give fluids and blood products. And the main therapeutic goal of the management, as we have been discussing, would be to have a hemoglobin of more than 8 gram per deciliter, platelet count of more than 75,000, prothrombin and APTT time less than 1.5 times of mean, and more than 1 gram per liter fibrinogen. The RCOG Green Top Guideline number 52 states that while results of coagulation studies are awaited, up to 1 liter, that is 4 units of FFP and 10 units of cryo may be given empirically in the face of uncontrollable bleeding. So early empirical FFP might be justified if significant consumption is likely, as in placental abruption. And so this is a summary of the management. So your first thing, as we discussed, will be call for help. You assemble the obstetric team, the anesthetist team, emergency team. You call the neonatologist. You intimate the blood bank. You give a left lateral position, give high flow oxygen. You secure the ABCDs, that is IV access, take blood samples, replace fluid with crystalloids, colloids, or blood. You assess, you see her vitals, and you, with the history, you will know the probable cause, if it is a previa, placental abruption, rupture, vasa previa, abdominal examination, vaginal examination. Important from obstetric point is unless it is a placenta previa abruption is clarified, PV examination is not to be done. And then you will see what blood products you need or what you have, what is the fetal well-being, the maternal well-being. Once you do it, then you ensure that the blood loss, blood products have been replaced. And if it is not, you expedite the process of birth. And you increase chances of PPH, so active management of third stage is done, uterotonics to be given, and then you monitor, measure the urine output and other parameters, you document and debrief to the mother and the family.
Thank you, Vinita.
I have some comments to make.
Yes, sir.
We have time?
Yes,
Yeah, sir, we have time.
Thank you. Vinita, the definition of abruption, you never mentioned about, although I just said the pathophysiology, you didn't mention about the trimester of pregnancy. So it is only in the second and third trimester of pregnancy.
I can't hear you, sir. Can you be a little loud? Sorry, sir, I can't hear you.
Though you didn't mention in the definition of abruptio the trimester
sir.
of pregnancy. So that is also equally important. And preferably the classification and what are the two things available to mention what type of patient we are dealing with. And next is in the one of the predisposing factors is the associated uterine anomalies, especially if there is a fibroid of a volume of 50 cc, then that also can provoke abruption placenta. So that is also one of the important factors. And there was a question from the audience, how do you dose your thiopentone?
How do you?
Dose your thiopentone in this patient? Or what made you to say that I'm going to give 250 milligram of thiopentone? Because their concern is you're moving a patient, you're fluid resuscitated the patient, you're moving a patient who had a BP of 90 by 50 and a heart rate of 110, and you are giving oxygen, you are giving a left lateral tilt, you have moved to the patient already moved in with these things. How did you decide about this dosage?
So thiopentone, we can do 3 to 5 mg per kg. My patient was 70 kg, so 350 mg. But since she was already hemodynamically stable, for rapid sequence, I would give a titrated dose. So I give a 250 mg of thiopentone, sir. And when it comes to if it causes more hemodynamic instability, as we have already loaded phenylephrine and ephedrine, so depending on that, I would give small aliquots of phenylephrine. And if required at that moment, I will give it before induction. I'll give 25 to 50 mics phenylephrine and then give thiopentone sodium.
Okay.
So just keeping that this can happen and preparing and mitigating it. So I think with that, we can use thiopentone, sir.
That's a good thing. So I anticipate that this patient you're dealing with was in shock as revealed by a blood gas and missing. So you instead of letting the patient go down the hill and pull her up, better to anticipate and give a dose of phenylephrine before you give the thiopentone along with it, and then so then you don't expect this fall in the pressure. Somebody has asked about whether you can give ketamine. Yes, there is no doubt at all, but absolutely propofol is a big no. It's a ketamine is also an alternate choice where you feel confident about the hemodynamic stability. Then there was a question about can colloid be given in these patients? Colloid, the current concept is especially the starch, especially these are the patients. Two things we are worried about: the mother or the cortical necrosis and renal failure, and DIC. So both are, and this is a young patient. So we are worried, especially when we use a lot of starch solution, but now the things are clear. In emergency patient, they never use starch. In critical care patient, they don't use starch because of the problem on the renal dysfunction. So if you're still pushed to the wall and then you don't have any blood and you want to buy some time to get some volume, then maybe you can consider gelatins. So that is, otherwise, you manage with crystalloids and then wait for the blood to come. So other peculiar thing in our country is this called as booked case and unbooked case. Sometimes even in Apollo, you get unbooked case. You'll be really in surprise. both the obstetrician and the thing, because if a book case, all the investigation would have been done, right from knowing the blood group to everything. So you are mentally prepared. But this unbooked case coming because of the tertiary care hospital, then you are in trouble. We do still see patient coming into the labor room, a book not seen by anybody before, in pulmonary edema with mitral stenosis. That is the patient they call us and then expect us to. So that problem is still there in our country, is unbooked case. If the book case, everything is there on already you know about the details of the patient. So these are some of the questions they asked. Anything else, Professor Bhajaji?
Sir, actually, Dr. Parna Thakkar ma'am has raised her hand. Can we unmute her, sir?
Pardon?
Yeah.
Parna Thakkar ma'am has joined. Yes, yes.
Yes,
Welcome, ma'am.
Yeah. Good evening, all. Very nice presentation and discussion. I just wanted to add one experience. So, like once we had received a patient with antepartum hemorrhage, and because of the massive blood transfusion, the patient went into pulmonary edema. And because the rate of resuscitation was very fast. And to this patient, and finally we gave PCC, prothrombin complex concentrate, and she came around very well. So there was a time when she was on massive edema and we had started Lasix infusion, and we could not give any blood product because she was in DIC at that time. So PCC came very handy, and I've also written an article on that. So, yeah, thank you.
Thank you.
Thank you, ma'am. Thank you,
One
ma'am.
thing I missed is the D dimers. Why nothing was mentioned about that? Because that is most
Yes.
for ongoing.
Yeah,
Whether
Yes, sir.
more than FDP will be the D dimers. Because now even a common man knows about D dimer thanks to
Yeah.
corona, and everybody knows about D dimer now, and that is more specific that things are going on.
Yes. Okay, sir.
Yes, we do. Yes.
Okay, sir.
Thank you.
Thank you. Thank you, sir.
Thank you, sir. Thank you, sir.
We'll take
Vishali?
few questions.
Take all the questions, Vishali.
Yes, ma'am. So, ma'am, two questions. Can it be used in pregnancy? Is it contraindicated?
Which, ma'am? Sorry, what is?
Etomidate, ma'am. Two of them have asked if etomidate can be used to induce the case, like in pregnancy. Is it contraindicated?
I think we don't use it at all.
Can etomidate can be used in these patients?
Yes, sir.
Why contraindication question came? Considering what? Anything written about that question?
No, ma'am. No, sir. The question was: is etomidate can be used in pregnancy? Is it contraindicated?
I don't think so. Any of the induction agent is contraindicated till date in the pregnancy,
No.
especially in the because these are the emergency cases only where we induce, especially.
Correct.
And moreover, if with I think many of the abruption cases or the bleeding cases, they do have some cardiac morbidity, and I think it has got a more protective role in those cases. Etomidate.
The next question is maximum dose of pitocin.
In which type of circumstances? It's a normal
Not many.
delivery, it's a section, or it's going to be a poly delivery. You have twins or triplets. What type of that? If you go with the research question of this, how much pitocin is good enough, rather than the dose of oxytocin, it is the route, it is the speed, it is the methodology which is more important, and it is a time when you give it. Because when you go to the old obstetric books, it was started like that with the delivery of the anterior shoulder and the tying of the cord, you give it. But I think if you give it in a diluted form, even 4 to 5 units of oxytocin over 3 minutes, that will be good enough to make the uterus contract and retract. Plus, I think during the time of stitching, you make the plateau level with the infusion of another 10 to 15 units. I think whatever the practice we have seen, so that is very, very good enough. And I have seen very rarely the use of even going to for the use of methylergometrin or prostaglandins, because it's a wisely used oxytocin, which is going to create almost 99% of cases the uterus contract and retract.
Yeah. I agree with that. That's absolutely how we work on it. The only thing is, the higher, if the speed is high or by mistake the transfusion goes in too fast, then they immediately start having nausea, vomiting, tachycardia, hypotension,
Tachycardia. The cardiac comes
hypotension,
immediately.
and that itself is a sign to slow it down. So they have to keep watching clinically. So there is no top, top end of the dose. So we usually titrate it to in theater 5 units and then 15, and then once that's over in the recovery, if she still needs, add another 20 units and run it at 75 ml per hour for the next 6 hours. By then hopefully the uterus should be very well contracted.
And one more important part of titration is keep asking the obstetrician whether the uterus is fine. You are satisfied with the uterus contractility and retractability. So if the obstetrician is fine, I think this is the best person
Yeah.
to at least to gauge your titration rather than just using and something like that. You may not be able to aware. It's a feel of the uterus which gives you more appropriate, response of the oxytocin.
They call it the cricket ball consistency.
Very hard.
Yeah.
Yeah.
Ma'am, next question is carbetocin better in bleeding patients?
See, I think we don't actually have evidence to use carbetocin in unstable or high-risk patients. Whatever evidence we have is for low-risk patients in primary and elective scenarios. So I personally haven't tried using carbetocin in high-risk patients at all. We've stuck to using syntocinon and the next line being carboprost, and there is no literature evidence either. Anything to add, Dr. Bajwa?
Yeah, definitely. Because prostaglandin F12, wherever you want to use the carboprost, it's more of a choice of a obstetrician, because they have got more exposure to these type of cases rather than we anesthesiologists, because they are invariably handling the bleeding cases. You may be handling 1 or 2 cases, they are handling all the bleeding cases, and they very well know when to use it, when not to use it, because they always keep it a third line drug.
Yeah.
If you ask me, they always keep it a third line drug, but also we keep in the same way. But sometimes what happens when the patient's life is in jeopardy, there is no ego using it also. I think that times, sometimes out of panic, out of sudden rush of catecholamines, adrenaline, we use it when the bleeding is, very severe and very, very aggressive bleeding is there. They can use it. I have seen them using it and it produces result. It's not like that it does produce results, but I think again, it's always a teamwork to at least when to use prostaglandins. As an anesthesiologist, I have not, volunteered myself to use it. It's always the decision of the obstetrician, because they are in the very much the site of that bleeding, where the bleeding is coming from, what are the factors which is causing the bleeding, how much uterus is playing its role in the bleeding, the tonicity and other factors. Sometimes there is a more traumatic bleeding is there. Sometimes the coagulation profile may be, deranged. So many factors are there in causing the bleeding. It's obstetrician who should be the taking the lead in giving the prostaglandins here.
Yeah, I agree on prostaglandins. I think they were talking about the carbetocin. So carbetocin, I think we don't have much experience with in high-risk mothers. So for the carbetocin. So
I think we should stick to the basics, whatever we have got,
yeah.
even because majority of our cases bleeding, they don't get time to go to the higher centers to the, So I think it's better to use whatever the drugs you have got, but only you should know how to use them wisely. That's more important.
Yeah.
Ma'am, next question, I'll club up 2 questions, ma'am. Can colloids be given if blood has not arrived? And what is better, ma'am, gelatin or starch?
I think Sir has already answered that.
Has answered it.
Absolutely, because the starches are a no-no in the current trend, and we have enough evidence. And if at all there is a absolute requirement, it would be gelafuscin. We just stock it in the emergency card, but we very rarely use colloids in pregnant women. I think that's what Sir had already mentioned. So yeah.
Ma'am, regarding crystalloids, ma'am, which one is better? Any?
I think balanced
One
salt
of them,
solutions
yes,
are
ma'am.
yes. I think NS is out of gun.
Ma'am, any role of calcium gluconate in this case, ma'am?
In case of abruptio placenta.
Yes, ma'am. Yes, sir. In this scenario, can we use
Because
calcium?
of massive transfusion, if they need to give calcium, at the end of massive transfusion, we would give our gas ABG would give us an idea what the calcium is, and we would titrate it based on that.
I think if you go by that simple methodology of whether you're giving the PRBC or you're giving the whole blood. Now, in both the bags, you have got almost 49.5 ml of the anticoagulant is there. So to balance that anticoagulant, at least for every 2 units, when you are proceeding for the massive transfusion, you have to inject at least the calcium gluconate. And if you are going at 3 bloods, then 1 ampule of the calcium chloride can be given because its concentration is a little higher. So I think if we're going for the massive transfusion, we are anticipating after every 2 bloods, at least give 1 calcium gluconate over 5 to 7 minutes, slowly, 10 ml of that. So that will be good enough.
Yeah, absolutely.
And one question is in suspected abruption with stable hemodynamics, but there is ongoing bleeding. Is there a role of TAG? Like, can we do TAG and give a spinal?
You want to answer, Vinita? Vinita, are you going to answer?
If there is stable mother, stable baby, and we are very sure that there is no feature suggestive of any coagulopathy, there is that breast, they can be given regional anesthesia, ma'am. They can be given. There is no evidence saying that it cannot be given. It is completely on the choice of anesthetist, and they
Yeah.
can be given.
Yeah, so they wanted to know if there is a role of TEG. If you do have TEG, I think it would be great to know have TEG or bleeding CT. And if it's a stable patient and there is no coagulopathy and TEG shows no coagulopathy, yes, regional anesthesia can be done. There have been cases where if it's a contained bleeding and patient is stable and no potential coagulopathy, regional has been done. Yes.
Ma'am,
And I'm also afraid of 2 things here. If the patient is non-fasting,
Yeah.
definitely the balance tilts toward that thing.
Yeah.
And difficult airway also. If you're
And
anticipating
obese
a very difficult
mothers, obese
I think
mothers, pre-eclampsia, hypertension combined with abruption. I think all of which, I think weighing the risk benefits, we would go ahead with a single shot regional.
also, ma'am, Bajwa sir just made me realize that sometimes you have to think beyond. You should not just stick to abruption and think about spinal. If you have to also consider the basics, if the patient is fasting or not, and this thing.
Yeah.
Thank you, sir. Ma'am, next question is by how much the fibrinogen level will be raised if we could give 1 unit of fibrinogen concentrate, ma'am.
Yeah. You have the table with you, Vinita?
No, it is like 1 gram of fibrinogen concentrate will increase 40 mg per deciliter in patient's body. If you give 1 gram, it will increase by 40.
You have that 1 vial, I think you just dilute it to 100 ml, that raises to about 2 to 4 grams. So that is what they actually say. So
do you have experience of using it?
we have actually used it here, and that is why I'm
How
so,
much is the
because we are
cost
so
actually?
short of blood products during COVID times. That is when we actually started using this, because of the liver unit, we have access to fibrinogen concentrate, and we actually had to chance to use it. It's about 10,000, I think, the one that is available here, 1 vial.
Ma'am, next question is, sorry.
I think it's good for trauma patients also. If you're getting Apollo, you get a lot of trauma patients also.
Trauma patients, liver patients, liver unit, they
Liver
said
patients, yeah.
they only suggested it to me, and at that time the paper was coming up in Wales. So then I thought, why we will also try. So it was into it.
Ma'am, next question is role of multiple ABGs in acute blood loss, ma'am.
It's not about multiple ABGs, it's as and when required. So it's the initial assessment, and then you've done your treatment and you want to know which way the patient is doing. You can either do a blood gas or wait work if your clinical picture is not giving you an idea. So any investigation should be only done if necessary. It is not just to put a record on the notes. So if you have done something at 6 a.m., she came in bleeding, you finish the case, come to recovery by 9 a.m., and you want to know whether something more has to be done or how to decide the next 6 hours of treatment, you do a blood gas. So an arterial line would be ideal, so we don't keep poking and hurting the patient, as well as making unnecessary invasive procedures.
Absolutely. I think this is the right answer to this question. And moreover, I think many people, keep ordering that ABG every 2 hour, 4 hour without realizing what is the clinical improvement. You should have some endpoints. You should have some starting points. You should have some middle points where you should be switching over to the investigation, stopping the investigation or modifying it, or modifying the duration of investigation. Sometimes you keep on asking very simple thing, a diabetic patient coming to you, oh, it's a very unstable diabetic, 2 hourly blood glucose level. But and you keep on doing, keep on doing. And although you are giving the regimes according to that requirement, but unnecessarily so much frequent investigations are not warranted and not advisable also. You should have some clinical acumen also how to go about it. That comes the role of intensivist there and the anesthesiologist role there.
Absolutely. So if that investigation is going to make a change in treatment, then we have to do. Otherwise, if you're just watching for trend, it's only once in 24 hours, in an acutely sick patient.
The last question, I don't know whether it will come under our terrain today. It's a fluid management in mitral stenosis, but the person has not specified in a patient of abruption, having a mitral stenosis, or it's mitral.
Dr. Bhaskar's area.
Yeah, Dr. Bhaskar's question.
Sir,
yeah. What is the question like?
Don't.
The
Sir,
question
patient,
is,
I will frame it. Sir, a patient of mitral stenosis coming to Apollo Hospital, Chennai, with a sudden abruption and coming to women's hospital or coming to the main hospital, where have to manage this case?
So if the mitral stenosis patient with mitral stenosis have gone through all 3 trimesters of pregnancy without problem, that means that itself indicates that it's not a severely critical mitral area. Okay, so if it was a critically area is very small, then she would have manifested it in pulmonary edema in the 2nd trimester or the 3rd trimester. But again, concern is with abruptio, with the pressure falling, you have one more thing to be a little bit aggressive on the hemodynamic monitoring. Maybe you can, if the mitral stenosis is so severe, then you can put in a Swan-Ganz catheter during the abruptio and then make it available before you induce the case. Otherwise, the management will be almost similar to what they have meant. The only other problem is the uterotonic ergometry will be a big challenge when you want to give, but you can manage without ergometry, and those usual precautions of mitral stenosis must be kept in mind. How much of fluid resuscitation, when to stop, what to give, and so all in these patients, the additional monitoring will help you how to go about this case.
Yeah,
yes, this is a big challenge. Already the patient, you have got a pregnancy, changes in pregnancy, abruptio added, you're adding a mitral stenosis, and so it's a real challenge. And then it is absolutely case. It depends upon the particular case, and you have to manage. But this history will give an idea how the patient has gone through these 3 trimesters of pregnancy. She is still walking around well before the abruptio. That means she's reasonably okay.
And just to add to that, I think these type of patients, if the mitral stenosis is severe, if you think it's severe, they will present with a heart failure during the 30th to 34th week of pregnancy. That's the time the most vulnerable these patients are. So if the patient have survived that period, I think the mitral stenosis is not that severe. Size is not always the indicative of that 0.5 centimeter square, is not that always indicative of this one, the severity. It's also the hemodynamics. Already you have seen the jump in 15 to 25% of the physiology in these patients. And if they're tolerating that, if they're coming to you and silently without any clinical symptomatology, I think what sir has said is absolutely true, how to manage these cases.
So still the challenge is in the labor and then the uterus contraction, the auto transmission. That is again, that can tilt the balance in mind.
Increase
uterotonics are little bit, you have to be careful when you try to the process.
So fluids, I think we would just titrate based on the CVP and filling, no, sir. So rather than gushing, I think earlier the patient gets to theatre, the better with abruption. Great. Thank you,
Anything
sir.
more, Vishali?
Sir, one question is about Ryle's tube in emergency LSCS with full stomach. Like, will we put Ryle's tube?
You know, one thing I'm telling you now, this is my experience here. I was a senior resident in 2002, I'm talking about. So at night at 1 o'clock, the patient came with the complete meal and sudden, distress, a fetal distress, and taken to the operative room. I told that this AP of obstetrics that the patient is non-fasting. What can I do? Is can his fetal distress just is anesthesia do, abhi do. I told that the patient is non-fasting. You just do one thing, put a Ryle's tube, take out every food, then you give anesthesia. I was so much, decision making was so difficult at that time. What to do? I only thing I could do as a pray to God that the spinal should be sufficient enough, and that's the first thing. Whenever the non-fasting patient comes, you cannot take out all the food out of the stomach, even if you want to, and that's not a recommended treatment also. Moreover, when such patient comes, always go with the at least this one. Go with the pentop injections and go to the MSET. Give some gastrokinetics that the forward peristalsis is maintained. That is very important. The time you put a Ryle's tube, you are making that gastroesophageal sphincter
Open.
more open. If the food is maybe in the intestine, when you are manipulating the abdomen for that this pressure, this fundal pressure, you're putting it. Somehow that pressure is coming back also. So that time, anytime, the patient may get a sudden vomiting and regurgitation. I think always aspiration chances are there. So better if the patient is coming, you at least explain to the relative the patient is full stomach, whether we give GA or regional. But we are always ready for a GA. Whenever we are giving regional, we are always ready for GA. At least explain to the patient relative, document it on the file that the patient is non-fasting and the distress is so much that even the obstetrician feels if the patient is not operated immediately, it will be a havoc for both the fetus and the mother. So get that documented and then you proceed either with a regional or with a GA, whatever the thing is. Whether you go for the rapid sequence induction for the GA or you go for the previously called rapid sequence, regional also, spinal also. So whatever method you want to choose. But the documentation in this case is very, very important, I'm telling you. But putting Ryle's tube is putting a danger, putting yourself into danger rather.
I think the reason they asked that question is, GA, I think some of the gastric ultrasound people have suggested that you check the gastric ultrasound, empty it, and then do for the airway. I think there is one school of thought, but I believe that even if you put something, you should take the thing out before GA because it is a pathway for more reflux to come out. You should take it out.
Intestine care also, the duodenum, jejunum, ileum, whatever.
Anything
Back peristalsis can come out anytime. It's not that they will not come out.
Yeah, correct.
Anything else, Vishali? I think a screen has stopped for a network. In the meanwhile, at least when Vishali comes back, we can have some important part. My screen visible?
Yes.
Yes, sir.
So Vinitha, I think you really, it was bubbling. The confidence in you was bubbling today. The topic was not so easy. It may look easy, but it's a very, very tough topic. And you did a wonderful job. And I really salute your teachers, both Bhaskar sir and Dr. Vanilla, for preparing you to this level. This was a tough topic. And you did answer very well almost every question.
Just want to inform her she is a primary candidate.
Yeah.
And
great.
she has shown a lot of enthusiasm in learning. So I think she is in the right track.
So Dr. Vanilla, because it's for your area, special area, you are handling the entire women's hospital in Apollo. So that's a wonderful job, a class, and you took it on a short notice. That's another, I think, feather in your cap also, having a national class on this antepartum hemorrhage and anesthetic management. Thank you very
Thank you
much.
very much, and thank you for always.
Particular thanks to the Professor Bhargav,
And
Himani,
Dr.
and Shyam.
Bhaskaran, sir. Sir,
No, no.
Apollo has grown under you, basically. Apollo has grown under you over the years, and all the hospitals, whether it's a women hospital or it's a child hospital, Apollo, all the hospitals have grown under you. And we are thankful to you to sparing your precious time here. I know how busy you were there when I met you in the Apollo. You didn't have a time, but you spared that special, precious time for us. I think, thank you very much, sir, for coming today.
Academic. So only thing is we are not getting proper information about this academic activities of ISA. We have what is conducted in the local. We are getting all the information.
No, sir, actually the groups are there. All the city state groups are there. I will try to add you people there in those groups also.
Okay.
So in the Chennai group is also there. Two, three groups are there of Chennai.
Yeah.
So I will add you there in those groups.
Because we are getting all the activities of Tamil Nadu chapter, but not the ISA of.
No, sir, my promise to you, after this class, I will be adding you in those groups.
Sure. We want everybody to benefit, actually.
Yeah, sure, sir, sure. Then, Himani, I think you are still busy in the operation theater and you are doing a good job. And sir, these are our young stars who are rising and they are very confident of conducting and anchoring these classes. And especially Vrushali also. She did it was a debut. She was a new SR, but she did a wonderful job in screening this class and coordinating with us. Thank you, all of you, for this class and bringing it to such a good result. I think the discussion was also good. We just have 5-6 minutes, and anybody wants to suggest or anybody wants to ask a question, they
There's
can.
one, they asked for intraop analgesia in this case.
Yeah, I was just going to ask her at the end. Vinita, you can go ahead.
Once the baby is delivered, I'll give fentanyl 100 micrograms, ma'am, and paracetamol 1 gram IV intraoperative. And if we are sure that coagulation is fine, there is no bleeding issues, then we can also go with ultrasound guided transversus abdominis plain block, ma'am.
But this patient, we said that we are still waiting, right?
Mm.
So we're going to
Yeah,
shift
so
Yes,
then I will just go for paracetamol and IV opioids, ma'am. Unless we are sure about the coagulation and everything, I would not like to go for any regional or needle poking, ma'am.
Yeah, so we may not want to give a block unless we are completely sure. And just before waking her up, we may consider. So what about the role of non-steroidals in such DIC?
Similarly, when we are sure about the renal function, post-operatively, we are urea, creatinine, urine output, everything is fine. And then we can go ahead with any non-steroidal anti-inflammatory NSAIDs.
Yeah, so I think it's
non-steroidal.
At this stage, we would avoid it.
Yeah, avoid a non-steroidal.
Yeah.
Yes, sir.
Only
fentanyl and paracetamol are good enough.
Yeah.
So challenge the patient with non-steroidal.
Yeah. So
and local infiltration, ma'am. Local infiltration would be good.
Yeah. It's fine. So multimodal approach, opioid would be the mainstay, considering the patient is still intubated. Add on paracetamol, and you can supplement with local infiltration if suitable. Otherwise, we would by 24 hours the patient should be up and ready with paracetamol.
Role of tab block.
That's what she was mentioning, sir. Role of tab block with coagulopathy we wouldn't be doing. So once she's settled and the coagulopathy is reversed, maybe we will consider doing it.
And that too in the hand of experts, I think. Tab block.
We don't want any new problems.
Yeah. So I think all the questions are over. Nothing is left. Himani, anything there? Himani?
I think there's one more question, sir. They're asking local infiltration with 5 ml bupivacaine plus 5 ml lignocaine or only ligno.
What's the point of giving lignocaine for a pain that's going to persist? So you'd be suggesting only a long-acting drug, not a short-acting drug for post-op analgesia. So it should be either bupivacaine or ropivacaine, 0.25%, 2 ml per kilo. So you can have a maximum of 20 to 40 ml if you're doing a block.
Dr. Mohan Pathak, sir,
One
boliye.
raise their hand, ma'am. Mohan Pathak.
Dr. Mohan Pathak is there. Is asking. Yes, sir.
Hello. Sir, I very much appreciate your suggestions like putting RT in. It becomes it will create a way to reflux. Other than when the such situations are there, usually most of the obstetricians are not trained in putting B-Lynch stitch or internal ligation like thing which can stop the bleeding, and ultimately you have to be you get land in a great problem to find some obstetrician who can do all this internal ligation or B-Lynch stitch to stop the hemorrhage in case of uterine atony or some these problems.
Yeah, so that is actually there in the
Vasodilation.
extremes of cases we have seen when the hemorrhage is not
Yeah.
stopping in spite of using all the three lines of
Yes.
and all the
Yeah,
measures,
all
the physical measures also, because the uterus is open to the obstetrician, doing all the kneading and doing all the packing, and if still it's atonic, I think then the
Yes.
only God saves us, then that's the internal iliac artery ligation.
Yes.
I think that has been done, but it's a very rare step, I think, with the present day medications and management, I think. Sir, obstetricians have also advanced a lot. So I think in this class, if the obstetrician would have been sitting here, so we would have got a better management in such cases, how to have a coordinated effort to go ahead in stopping the bleeding in saving the patient's life. So definitely iliac artery ligation was there, I think few years ago, 2, 3 decades ago. It was there, but now it's done only in the major cases, sir.
Yeah. I think it's predominantly helpful, if I may add, sorry, for things like placenta previa, even elective internal artery ligations are done. So to prevent blood loss, and it actually prevents us from going to embolization and radio units.
Yeah.
So
Emboli.
they're actually electively used, and if the surgeons nowadays, I think their skills are improving. Obstetricians are actually taught on an elective basis because they're doing a lot of laparoscopy. The anatomical access to the internal iliacs have gotten better, so they are able to do that with. But it's always good to get a general surgical or vascular help handy.
If it is a PP, I was saying, sorry, placenta previa, and you can even radiologically, you can block it, the block, and then take the patient for surgery and then.
Yeah.
That will also
Yes.
be.
There's always a lot of options.
Anything else is there?
So we have few compliments too, that it was a very student-friendly lecture and good lecture like that, sir.
And to tell everyone, this all these lectures are recorded and they will be available in the ISA and HQ at YouTube when the class gets over. Anybody can watch these lectures later on for appearing in the examination. They will be thanking Dr. Vinitha for presenting such a case, and they will be thanking Dr. Bhaskaran sir and Dr. Vanilla for at least exposing all the questions being asked in these type of cases. Whether it comes a short case or is a long case, they will be able to, even in theory also, they will be able to answer many things. These are the more practically oriented classes and where the students gain like anything. So I think that's a wholesome class, you can say. It's a whole blood. It's a wholesome class.
Yeah,
One last question, sir.
that discussion is always there about whole blood versus PRBC. I think we are coming back to whole blood again. Bhaskar sir, isn't it so, sir? In cardiac, you always use whole blood, sir.
Pardon, sir, sorry, I didn't.
Whole blood, use of whole blood in obstetrics. I think we are reinventing
our
the wheel.
surgeons, but blood bank is very clear now.
Yeah.
We still have a surgeon who says you do not know the problem. He goes personally and then gets, because this has got everything, and single blood, not multiple sources of blood. So you get FFP and platelets, everything when you give in a single donor. So and then it's a warm blood. He wants it to be collected and then transfused immediately. He feels it creates a lot of wonders, especially in these type of patients with a lot of bleeding. Otherwise, the concepts are very clear. It's only formed elements.
Products.
But if you want to decrease the load, maybe you can have a single donor platelet transfusion. So that can be given. If you want to decrease the number of people, donors.
I think anything left, Rushali?
Ma'am,
No,
I have
sir.
one last question, ma'am.
Himani is
With
coming
my
for.
doubt. Actually,
Yeah,
ma'am,
tell me.
what is the endpoint for when do we know that we have to stop these products like the FFPs and the PRBCs in the setup? Like we don't have a thromboelastography or anything. So how do we know what is the endpoint for this
So,
products?
if you ask me honestly, there is no endpoint actually. You can precisely define, but I think having a more visual in the operation theater is the clue to the endpoint. How much loss you have seen, how much blood loss you have seen, what was the pre-operative hemoglobin, hematocrit values, and how much of blood loss has been there, taking from the gauge, all the gauze piece and all the, the pads and whichever sponges you are using, just I think weighing them or whatever the blood, if you are precisely want to replace. Even if you replace almost 70 to 80% of the blood which has been lost, I think that is good enough. You can't say that I have to replace all the 100%. Even the three-fourths of the blood replacement is good enough in such cases. But even that is also just a arbitrary, endpoint. So endpoint is the most important is the stable hemodynamics. If you want to see clinically, the stable hemodynamics, you may not be in the periphery, you may not be able to have a, arterial blood gas immediately, because when the lactate levels or whatever the carbonate levels you want to see, you may not be able to get those reports in the peripheries. But I think those will also help. And moreover, the clinical acumen is the best way of getting the endpoints rather than objectifying it that this much should be there. Because even if you replace blood, it will take some time for hematocrit to stabilize and to acquire the new value. So that will not be easily measurable indices index in that vicinity of your replacement. So all is a, I think majority of the time it's a clinical acumen and then partly is objective. So there is no precise endpoints like that. I think you can add Dr. Vanilla and Dr. Bhaskar, sir, you can add more to it, I think.
Yeah, I mean, clinical acumen, see, we look at the surgical site, whether it is still oozing, whether the blood is looking clean, the end organ perfusion, hemodynamics, pupils, cardiac status, what is the pulse volume like, what is the color of the skin, what is the urine output like. So end organ perfusion gives you an idea of stable hemodynamics, oozing of the surgical site. And then if you do have blood lab values, hemoglobin, your target is always been anything above or equal to 7, INR, coming, if your hemodynamics coagulopathy should be coming down and the platelets should be greater than 75,000. I think that is what we are looking for. So clinically is what we mainly look at. So if it's been an oozy surgical site and once it starts clotting and the uterus is well contracted, we will get an idea. I think that's what we normally do and then reassess the situation in recovery.
Definitely.
I agree with
Dr.
Vanilla. Once we mainly go by these are all young patients, all pregnant patients are all young patients. So if you build up the hemoglobin to 30 plus, PCV to 30 plus, then you're not worried much about this. So long there's no bleeding, that means the coagulation factors have been adequately compensated. So don't worry about those numbers. If you build up the hematocrit to about 30, 34, 33, 34, you stop at that and then go by the arterials of the feed. So that gives us the confidence and then we leave. That means our patient has been managed well.
Great. Thank you.
I think it's done.
Yeah.
And really thank to the team Chennai Apollo because they've done a wonderful job for this class and every question has been answered in a very well manner. And our debutant, Dr. Rushali and Dr. Himani, both have done a wonderful job. And so is Vinitha. Confident, I think she will she'll become a good obstetric anesthetist in Apollo Chennai only if I do a SRship there only. So that's the best we can do. And I think we should end it now.
Yeah.
And we always end by saying, long live ISA.
Long live ISA.